to welcome all of you and our two speakers to the session on asthma and bronchiolitis. First speaker is Fabio Medulla. You all know very well, previous head of assembly and long-term organizer, co-organizer of the summer school, organizer of the ERS Pediatric Bronchoscopy course, and a long-standing researcher and clinician in the field of bronchiolitis, and I'm very much looking forward to his presentation on acute viral bronchiolitis.
Thank you, Monica. So I have no real conflict to give this lecture. So we all know that acute bronchiolitis is a viral infection of the lower respiratory tract and is one of the most important health problems for infants around the world. But we know that the clinical management remains challenging despite the frequency, global reach, economic cost, morbidity, and mortality. We know that the diagnosis of bronchiolitis is clinical. We know that the peak incidence is between 3 months and 6 months of age, but we also know that bronchiolitis in toddlers can overlap with other conditions, such, for example, a viral-induced wheezing episodes. We know that in the first year of life, almost 70% of infants, so that's mean 1 on 5, will be infected with the respiratory virus. Around 22% will develop symptomatic disease. 2 or 3 of these children will be admitted to the hospital in their first year of life because of severe bronchiolitis, and of this, 2% will be probably require intubation and mechanical ventilation. I know that there are more than 30 guidelines that have been published so far on the treatment and on the diagnosis of bronchiolitis, but despite this, there are several gaps and controversies in the management of bronchiolitis, such as the definition, which are the most appropriate diagnostic examination to perform, when to admit a child with bronchiolitis, what to do, which is the specific treatment, and when to discharge the patient from the hospital. I think that definition is one of the crucial points when we speak about bronchiolitis. As you can see from the slides, there are 2 major definitions of bronchiolitis. The European definition and defined bronchiolitis, infection of the lower respiratory tract in infants less than 12 months of age, and the major lung sound are diffuse crackles. On the contrary, in North America, the defined bronchiolitis in acute wheezing episodes in children less than 2 years of age. So it is evidence that bronchiolitis represent different diseases that may share similar biological mechanisms that we define endotypes, or similar clinical features that we define phenotypes. It is important the lack of a clinical definition, a clear clinical definition, may have implication for the interpretation of clinical trial and basic research study, and I'm sure that the precise definition will have an important role for a personalized treatment. This is what is coming from the different guidelines. I show here what I think are the most important. You can see that they define bronchiolitis in children under the age of 24, under the age of 12 months, under the age of 18 months, first episodes, second episodes, and also about the lung sounds that define a child with crickles, wheeze, and crackles. I think that we were the first to demonstrate more than 10 years ago that probably in the clinical definition of bronchiolitis, you may have different phenotypes and endotypes. In this study, we compare bronchiolitis from RSV with bronchiolitis from rhinovirus, bocavirus, and dual infection. And what we saw that infants with RSV bronchiolitis were younger, had a more severe bronchiolitis, and they have a lower concentration of blood eosinophils comparing to infants with RSV bronchiolitis. And several years after, we were able to show that infants with RSV bronchiolitis have a different, Th2 response comparing to infants with rhinovirus bronchiolitis. So two different biological immunological response. Stage 2 in infants with rhinovirus and Th1 in infant with RSV bronchiolitis. And these slides coming from a study that we're trying to publish now with a very sophisticated statistical analysis. We try to see if in the clinical definition of bronchiolitis we may find different cluster of patients. And I would like to draw your attention to the first two profiles, A and B, where it's clearly shown that profile A are infants with a more atopic characteristic comparing to profile B that have a more severe characteristic. So we can say that in the future, with the transcriptome, viral genome science, metabolome, microbiome, together with the genetic characteristic of the patient, under the umbrella of bronchiolitis, we'll have a bronchiolitis of phenotype A, B, C, and D, and this will be very important for the treatment of the patient. So let's move now to the clinical course of bronchiolitis. We all know that the incubation period of a child with bronchiolitis is from 3 to 5 days. In the first days of disease, the child presents just symptoms of upper airway infection. But what is important to know, the course of the disease, because usually the severe respiratory distress, reduced food intake appears between the 3rd and 5th days of disease. And during these 3 days, you may have minute-to-minute variability in lower respiratory symptoms because of the continual formation of mucus plug in the terminal respiratory bronchioli. So it's very important to know when you see a child with bronchiolitis that usually they get worse between the 3rd day and the 5th day. So something is when you see the child on the 1st days of disease, and the difference when you see the child on the 5th days of the disease. We all know which are the clinical symptoms of a child with bronchiolitis, but I would like to underline just 3 things. The first thing is that fever, high fever, is very uncommon in children with bronchiolitis, and usually is present in less than 30% of the patients. So in the presence of high fever, you should carefully evaluate for other causes, especially if the child has less than 30 days of age. Increased work of breathing and poor feeding, again, remember that they usually happen between the 3rd and 5th days of the disease. And the main sounds are rales that are diffuse. If you have a child with fever and rales that are localized, you should always think about a differential diagnosis. You all know that there are risk factors for severe disease, the age, significant comorbidities, atopy, some social factors, and when you have a child with socioeconomic deprivation, you know that this child may be kept in the hospital because of the parents that are not attendable. Which are the diagnostic examinations that we should perform in a child with bronchiolitis? And again, I ask the help of the different guidelines. And as you see, routinely, there is no need to perform a chest X-ray in a child with a clinical diagnosis of bronchiolitis. For pulse oximetry, the guidelines, they are not agree in the same treatment. Some of them think that it's important to do an intermittent checks to all the children that arrive to emergency room should measure oxygen saturation with the pulse oximetry. And for example, in North America, they recommended pulse oximetry only if the child needs oxygen supplementation. And here about the viral testing, only one cohort, the Italian one, and the Spain and the Scottish suggest viral testing for cohorting. No reason to do white blood cell count, no reason to do blood culture for bacterial superinfection, only in infants less than 1 month in France, the guideline done in France, and blood gas analysis only if you have a severe respiratory distress. So when we should admit a child with bronchiolitis, And this is what is coming from a study. I want to show this study that's, in my opinion, is very interesting. 171 infants aged from 0 to 6 months that were recruited by 18 community pediatric pediatricians. Then children were divided in those that were receiving less than 50% of food intake during the previous 24 hours, 50 to 70 and more to 70 and more than 50. And what they show that 24-hour food intake had a sensitivity less than 50%, as a sensitivity of 60%, a specificity of 90% for an oxygen saturation of 95%. And it is the highest whole rate for oxygen saturation less than 95%. So taken together, the studies show that clearly the most important things that you should take under consideration when you evaluate a patient with bronchiolitis is the food intake, but usually come 24 hours before the reduction of oxygen saturation. So when you should hospitalize the child, when there is a persistent oxygen saturation less than 92% when the brief airing, decision-making for hospitalization when the child has an oxygen saturation between 92 and 94 should be supported by the clinical assessment, social factors. What is important, inadequate oral fluid intake between 50 to 75 or usual volume, severe respiratory distress, apnea, and the risk factor for more severe bronchiolitis that I just showed before. We know that when the child has a severe respiratory distress, it is not able to maintain oxygen saturation around 92% with a VO2 of more than 60% of recurrent apnea should be admitted in intensive care unit. When let's go now to the treatment. That is probably the most important part for you. You know that when we treat a child with bronchitis, we should consider supportive care and medical care. All the guidelines agree with you give the fluid either by nasogastric tube or IV. There is a difference on when give supplemented oxygen. In North America, they recommend to give oxygen when the oxygen saturation is less than 90%. In Europe, when the oxygen saturation is less than 92%. Another important supportive care is suctioning. That should be superficial and not too frequent, because we know that infants breathe mainly with the nose. I think that what has changed the natural history of the disease is the use of high-flow nasal cannula. You all know that with this technique, it's possible to give humidify and warm the oxygen to know how much oxygen you are giving at a pressure that is slightly higher the pressure of the inspiratory pressure of the child. And with this technique, it was possible to reduce the work of breathing and the need of intubation. There are two very interesting studies on high-flow nasal cannula in the children, and this is one of the two. The other one was published by Australian doctors in the New England Journal of Medicine. In this study, they compare oxygen versus standard low-flow nasal cannula administration versus high-flow nasal cannula, and what you see on the left panel is that there is no difference on the time on oxygen between treatment groups. So that's mean that the course of the disease is not changed by this technique, but what is changed is the need of mechanical ventilation for children that were with high-flow nasal cannula treatment. And so let's go on the medical treatment. You see that there is a complete consensus on no use of corticosteroids in children with bronchiolitis, no use of epinephrine. Some guidance recommended a trial with beta-2 agonists, mainly in older children and with those that may have atopic phenotypes, so family history for asthma, family history for atopy, and no reason for antibiotic therapy because bacterial superinfection is very, very rare in infants. And hypertonic saline, most of the guidelines recommended hypertonic saline, but the guidelines were published before this study that came out later on, where they show that there is no reason, no improvement in hypertonic saline in children with bronchiolitis. So when to discharge a child, this is another study that show clearly that the first things that the child will do again before recovery from respiratory distress is feeding. So feeding, the child start to eat 24 hours before it starts to be again with a normal oxygen saturation. So in conclusion, when we should discharge a child, when he's clinically stable, when he's taking adequate oral fluids, when he's maintaining oxygen saturation over 94% in air for 4 hours. So in conclusion, which is manageable bronchiolitis? Which are the key points? You should have a good knowledge of clinical symptoms and course. Try to define the phenotype. Fever is present only in 30% of the patients. So when you have a patient with fever, you should always think about the differential diagnosis. Food intake is the first to be reduced and the first to return to normal. And the peak respiratory symptoms and dehydration occurs between the 3rd and 5th days of disease. And supportive treatment, fluid, suctioning, and high flow nasal cannula, and medical treatment only a trial with beta-2 adrenergic medication if you have a child that have clinical feature, atopic history, and is older. So let's go to our question. The first question is, which of the following is not a risk factor for severe bronchiolitis? Prematurity, hemodynamically significant congenital heart disease, chronic lung disease, neuromuscular disease, and breastfeeding. So I think that you can vote, and we can see the. So I think that the question was very easy. Breastfeeding is not a risk factor for severe or for bronchiolitis. So let's move to the next question. The most important findings for assessing severity of bronchiolitis are a respiratory rate, work of breathing, level of oxygen saturation, and degree of cough, rapidity of heart rate, pitch of wheezing, presence of crackles, on inadequate oral fluid intake. So I think that we can, so 90% answer the right question, give the right answer. Inadequate oral fluid intake is the right answer. And the last one, among the following, the febrile patients most likely to have a serious bacterial infection associated with bronchiolitis are younger than 30 days of age, are between 13 and 60 days old, are neurological impairment, have infiltrates on chest radiography, have survival neonatal respiratory distress. So I think that you can see the voting. 64% gave the right answer. When you have a child that has fever and is younger than 30 days, you have a higher risk to have a severe bacterial pneumonia instead of bronchiolitis. Thank you very much.
Well, thank you very much, Fabio, for this tour de force through bronchiolitis, a very good clinical overview of evidence for clinical management. I think we have time for just 2 questions. There are many more coming up, but maybe we can take some of them together with Marielle. One is regarding the role of ipratropium. Is there evidence for that instead of salbutamol?
Okay, so as I show you in my presentation, before 2014, it was published a Cochrane that showed that ipatropio is there is no reason to use ipatropio, so there is no role for ipatropio. So I was thinking about the hypertonic saline. No, ipatropio, there is no reason. Okay,
and then what is there a potential role for physiotherapy in bronchiolitis?
Okay, there are only a few papers that were published on bronchiolitis on physiotherapy and with discordant results. I think that in the future, we should consider physiotherapy in the treatment of some of these kids, because in our experience, those kids that need mechanical ventilation and have a severe respiratory distress, and mainly those kids that have a complete lung consolidation, for example, of the upper right lobe of the left lower lobe. So, and I think that in these kids, especially if you can use non-invasive technique like ultrasounds, and you show that there are some consolidation, you can try to use this technique. So I would try to do some study in specific group of patients. But at the moment, the studies that are being published on physiotherapy, they are not conclusive. So they say that there is no reason to use it.
Okay, and you've been talking about personalized medicine and bronchiolitis. All the data you've shown are studies, so you have an average result. Do you think there is a role for the treatments you have discussed in individual patients? So, for example, you have a child with predominant wheezing, a young infant with predominant wheezing. Would you still go for a trial of salbutamol?
I'm sure that when we personalize, when we will be able to define the different phenotypes and endotypes in bronchiolitis, we will find a specific medication, at least for a short group of patients. Because in our experience, in the group of patients that we follow in our clinic, those that are higher age, those that have atopic phenotypes, or family history for atopy, family history for asthma, or they have a Th1, Th2, Th2 response, or mainly wheezing, they may have beneficial effect with bronchodilators. So I think that first we should define better what is bronchiolitis, and then the study should be performed with children that are better defined. Because if you put all the children together, at the end, the results are negative.
Well, thank you very much. It's really a challenge to put both bronchiolitis and asthma into one session for a 1 hour session. So we have to move forward, and now it's my pleasure to welcome Professor Peenenburg again, who will give an update on acute asthma or treatment of acute asthma and long-term treatment of asthma in children and adolescents. Mael, I can't see you yet. I can only see your slides, but there you are. Thank you.
Yeah, I hope my sound is also working now. Yeah, okay, thanks. So this is really a challenge when I understand that I had to talk on asthma treatment in school children, in preschool children, and acute asthma. Within 30 minutes, I felt like this, to be honest. So I had to make choices, which means that I'm not going to discuss everything on these 3 topics. I included quite a lot of additional slides, so there are more answers to many of your questions, I hope. So I choose to discuss only the pharmacological management of asthma in school children, and I would like to focus on the differences in guidelines. Participants come from all over the world, so some will adhere to China recommendations, others would adhere to national guidelines or to BTS guidelines, and actually there are quite some differences between these guidelines, and I would like to explain why this is. But first I would like to start with a very, very easy case for our first year students, medical students. I present an 8-year-old girl who presents to your clinic with episodes of shortness of breath triggered by exercise and contact by cats. The GP started her already on salbutamol, which helped her very good, and she used that for 3 to 4 times a month. She's allergic for cats and for house dust mite, and she had an obstructive lung function with 13% of bronchodilator reversibility. So what would be your treatment here? Would you continue this child on as needed short-acting beta agonist only, start daily inhaled corticosteroids, start as needed inhaled corticosteroids whenever the child takes a short-acting beta agonist, start a combination of as needed inhaled corticosteroids LABA, or daily inhaled corticosteroids LABA, or would you start this child on montelukast? So it already took me quite some time to discuss all these answer possibilities. So I hope you had enough time to start the voting. Okay, so most of you would start this child on inhaled corticosteroids, and I will come back to the answer in a few slides. So actually everyone will recognize this step up, step down scheme from the BTS guidelines, where if asthma is well controlled, you try to do a step down, and if you have uncontrolled or poorly controlled asthma, you will try to step up treatment. Here in the BTS guidelines, as you can see, children with infrequent or short-lived wheeze, they're actually in step 1. And in step 1, in the BTS guidelines, short-acting beta agonists are prescribed for as needed treatment. However, if you look at the JINA guideline, there is a small difference between JINA and BTS, because in the JINA guidelines or JINA recommendations, if children have symptoms twice a month or more, then children should be started in step 2 treatment, which is daily low dose of inhaled corticosteroids, and as an alternative, daily leukotriene receptor antagonists, or low dose inhaled corticosteroids taken whenever the child takes a short-acting beta agonist. So this is the alternative treatment in step 2. So if you compare these differences between BTS and JINA guidelines, in the BTS step 1 treatment is recommended as needed short-acting beta agonist, and JINA recommends as needed SABA, but with 2 alternatives: low dose inhaled corticosteroids whenever a SABA is taken, or daily low dose inhaled corticosteroids. There's also a difference in step 2. In step 2, in the BTS, very low doses of inhaled corticosteroids are prescribed if children need more than 3 doses of short-acting beta agonist per week, or if they have nighttime wakenings, or if they have had an oral steroid course during the last 2 years. And then they start on very low doses. The alternative are the leukotriene receptor antagonists. JINA step 2 recommends daily low dose of inhaled corticosteroids with an alternative for montelukast or low dose inhaled steroids whenever SABA are taken, if symptoms are occurring twice or more per month. So they are starting inhaled corticosteroids much more earlier than in the BTS guidelines. And then there's a confusing difference between the doses of inhaled corticosteroids. What is called a very low dose in BTS guidelines is actually the low dose in JINA recommendations. So why do JINA recommendations start inhaled corticosteroids much earlier? Well, actually, this is based on the TREXA study, which is already almost 10 years old. And this was a study in children between the age of 5 and 17. Almost 300 children who were all on rescue SABA, children with mild asthma. And children were randomized over 4 arms. And for this, for now, I only compare the rescue inhaled corticosteroids versus placebo. So there were 4 arms. The first arm, children received daily inhaled corticosteroids plus rescue inhaled corticosteroids whenever they had complaints. An arm on daily inhaled corticosteroids as needed, and placebo. And as you can see here in the diagram, there was the children on placebo. This is the dotted line, had the worst outcome if you looked at time to first exacerbation, and the children on rescue inhaled corticosteroids did better. So if you looked at the p-value, it was not really significant, but if you look in the figure, there seems to be a difference between placebo and as needed inhaled corticosteroids. If you looked at daily treatment versus placebo, there was a significant difference. So in step 1, rescue inhaled corticosteroids did better than placebo. A second study also tackling the same topic in step 2 is a study which recently appeared. This is actually an open label real world study in 206 Afro-American children where a treatment strategy of as needed inhaled corticosteroids whenever SABA were treated was compared with maintenance inhaled corticosteroids. And the primary outcome was a change in the ACT or childhood ACT test. And as you can see here, there was actually no difference between the two groups. There was also no difference in lung function or in exacerbations, and the cumulative dose of inhaled corticosteroids was lower. So actually, if you go back to the case, it really depends which guidelines you adhere to. But for BTS guidelines, the recommendation would be to continue with as needed SABA because the child only uses 3 to 4 times per month a SABA. But if you adhere more to the JINA recommendations, daily inhaled corticosteroids is a good choice as well as are as needed inhaled corticosteroids whenever SABA are taken. Let's take it a little bit further. This child returns after 9 months. Her complaints got worse despite daily inhaled corticosteroids, and her adherence seems okay. Inhaler technique is adequate. She doesn't have contact with allergens as far as possible. So what would be your next step in this patient who is uncontrolled on low dose of inhaled corticosteroids? Double the dose of inhaled steroids, double the dose of inhaled steroids and add as needed inhaled corticosteroids LABA, maintain the dose and add a LABA, maintain the dose and add montelukast, or maintain the dose and add omalizumab. So, give you some time. Can I see the votes? Yeah, thank you. So most of you would go for maintain the dose of inhaled corticosteroids and add LABA, but also quite a high proportion would go for doubling the dose of inhaled corticosteroids. So if you look at guidelines again, actually both guidelines have a preference for adding LABA, adding LABA to this very low dose of inhaled corticosteroids. But the alternative in the BTS might be to add montelukast instead of LABA. And JINA actually says there are 3 possibilities: low dose inhaled corticosteroids plus LABA, or increase the dose of inhaled corticosteroids, and as an alternative, low dose inhaled corticosteroids plus montelukast. Important to realize that most children show a differential response, which means that they respond best to one of these 3 treatment options. However, there are hardly any clear predictors of the best response to LABA add-on. So we can't really predict which child will respond best to which add-on treatment. So actually here again, there are several possibilities. I think doubling the dose of inhaled corticosteroids is a possibility, or you could maintain the dose of inhaled corticosteroids and add LABA, and not the preferred option, but maybe an alternative is add montelukast. Let's go to the little bit older children. Again, here is the scheme of the BTS for adults and adolescents. And actually, this is very similar to the younger children, except that in the algorithm for the older children, also a MART strategy can be used. So this means the combination of inhaled corticosteroids, LABA, as rescue treatment. However, if you look at the JINA guidelines, this is very different. First, for the older children, if you look at the preferred reliever treatment, again, this is as needed low dose inhaled corticosteroids plus formoterol, and SABA treatment is considered the other reliever option, so not the preferred reliever option. In step 1, there's a preference for as needed low dose inhaled corticosteroids with formoterol again, and as an alternative low dose inhaled corticosteroids whenever SABA are taken. Step 2 differs from BTS in the way that daily low dose inhaled corticosteroids or as needed low-dose inhaled corticosteroids formoterol. So this second option is not an option in BTS guidelines, and daily montelukast or low-dose inhaled steroids whenever SABA are taken are an alternative. So what's the reason for this difference between JINA guidelines and BTS guidelines? Well, actually, JINA places a big emphasis on preventing exacerbations. And the background for this is that patients who have apparently mild asthma are still at risk of serious exacerbations. And we all know the children were not known with asthma before and then suddenly appear at the ER with a really very severe asthma attack. Triggers are not always preventable. Think about weather conditions. And a high SABA use is associated with ER visits and life-threatening asthma. There's actually no evidence for SABA only in patients who have infrequent symptoms. And patients on inhaled corticosteroids have an increased risk of, patients on inhaled corticosteroids have a lower risk of severe exacerbations. So all adults and adolescents should receive symptom-driven or regular low-dose inhaled corticosteroids according to JINA, and this is really to reduce the risk of serious exacerbations. So the emphasis is put on exacerbations and not that much on asthma control. What's the background for this? Two important studies. I show you one in the New England Journal of 2 years ago, where actually step 1 and step 2 treatment were included in a 3-arm study of 52 weeks. First, placebo plus, well, actually SABA as needed versus budesonide formoterol as needed was compared. So this is the step 1. And second, as needed budesonide formoterol versus daily budesonide plus terbutaline was compared. So that's actually step 2. If you first look at the results for this step 1 comparison, so this is the as needed formoterol versus as needed budesonide, then you can see that there was actually that children on as needed SABA did worse than children on as needed formoterol budesonide. So the blue one is the SABA only, and the red one is the budesonide formoterol as needed. So for step 2, there was a preference maybe for the budesonide formoterol. If you look at this step 2 issue, budesonide formoterol as needed versus maintenance, actually then there was no difference. If you look at the second outcome, weeks of well-controlled asthma, actually then you can see that in blue and red, the SABA as needed and the budesonide formoterol as needed did not differ, but the budesonide maintenance treatment was superior in obtaining asthma control, well-controlled asthma control. So let's switch to preschool children. I would like to discuss a little bit on phenotypes, on pharmacological treatment, and I will focus on Cochrane reviews, predictors of response to treatment, and one slide on personalized treatment. 12 years ago, there was an ERS task force on preschool wheeze, and in this task force, it was suggested to make a difference between 2 phenotypes of preschool wheezing: the episodic viral wheezes, children only wheezing during viral infections, and the multiple trigger wheeze, more or less the children with the persistent asthma. So children reacting on viral infections, of course, but also on weather conditions, on exercise, on allergens. And the idea was that the children with the viral wheeze would respond better to montelukast, and the children with the multiple trigger wheeze to inhaled corticosteroids. However, in daily practice, it didn't really work. There was a lot of changes between the 2 phenotypes, so children could go from one phenotype to another phenotype. So this task force came with another statement a few years later, where actually they discussed that maybe it's not this episodic viral wheeze and multiple trigger wheeze, but it's more the severity and the frequency of episodes that should guide treatment. In the children with more the severe and frequent episodes, inhaled corticosteroids are the first choice for daily control or treatment. And in the other children, only if they have really frequent attacks, treatment should be started. Important message from this task force that any control therapy should be started as a treatment trial and schedule follow-up and see what the child is doing and stop whenever it's possible. And oral corticosteroids are only indicated in preschool children who are admitted to hospital with really very severe wheeze. And even in this group, the evidence is limited. So in the next two slides, I will summarize systematic reviews on treatment of children with preschool wheeze, comparing daily inhaled corticosteroids versus placebo with as an outcome severe exacerbation. There is a clear benefit for daily inhaled corticosteroids. If you compare intermittent inhaled corticosteroids versus placebo, again, there's a strong preference for intermittent inhaled corticosteroids when you want to prevent exacerbations. Comparing daily inhaled corticosteroids versus intermittent, there's not a very big difference, but only few studies. Daily inhaled steroids versus daily montelukast favors inhaled corticosteroids. And intermittent inhaled corticosteroids versus intermittent montelukast, there was no clear preference. If you summarize that in this slide, in children with more persistent asthma, so these are the children with a positive family history who are sensitized, daily inhaled steroids is clearly superior to placebo and superior to daily montelukast. If you look more at the children with the so-called episodic viral wheeze, less frequent symptoms, only after during viral infections, then actually most comparisons don't show a significant difference, except for the as needed inhaled corticosteroids versus placebo. This is the JINA recommendation for children under the age of 5, and as you can see in step 1, as needed short-acting beta-agonist can be used. That's the reliever. And in step 2, daily low-dose inhaled corticosteroids is the preferred option. And intermittent inhaled steroids and montelukast are alternative options. Step 3, double the dose. And step 4, you really should consider to refer to a specialist. This is a very interesting study from 4 years ago in the YAKI, where actually they did a crossover study in almost 300 children below the age of 6 years on step 2 treatment. Comparing step 2 treatments, I'm sorry. So they compared active inhaled corticosteroids versus active montelukast versus as needed inhaled corticosteroids. And the primary outcome was the time to first exacerbation and asthma control days. And if you looked at which child responded best to which treatment, it didn't differ between the children who were not sensitized and who did not have an eosinophilia. So you could, in all those children, it was actually the same percentage that responded best to one of the 3 treatments. But if you looked at the children who were sensitized and had blood eosinophilia, those children had the highest chance to have the best response to inhaled corticosteroids. So sensitization and high eosinophils do predict a response to inhaled corticosteroids. I think this is a very nice paper in the current opinion allergy and immunology, which actually gives a suggestion for a more phenotype-based approach. In children with persistent asthma, eosinophilia, and sensitization, daily inhaled corticosteroids are recommended, and that's what what I showed earlier in the slides as well. However, if you don't have eosinophilia and no aero allergens, sensitization, maybe also other options, maybe a good alternative like montelukast or as needed inhaled corticosteroids. In the children with intermittent disease with a low risk of asthma, there are some studies showing some effect of azithromycin early during the course of symptoms. But children with intermittent disease and a high risk of asthma, like a positive family history, intermittent inhaled corticosteroids or daily inhaled corticosteroids, if they have frequent symptoms, may be recommended. So this is not a validated approach. It's more a possible idea to come to a more phenotype-based approach. So I'll finish with some slides on acute asthma, and I will focus first on severity, of assessing the severity of an attack, and then I will discuss the management. So our patient presents at the ER with an exacerbation. At physical examination, she has decreased air entry in an expiratory wheezing, no retractions. She has a slightly elevated heart rate and respiratory rate, oxygen saturation in room air of 94%, and you start her on SABA and on corticosteroids. Which of the following statements is correct? A, this is a severe exacerbation. B, salbutamol with a PMDI and spacer is as effective as with a nebulizer. A 3-day course of oral prednisolone is better than a single dose of oral dexamethasone. And D, she should be started on oxygen. So can I have the votes, Amy? Okay, so very good. The correct answer here was that salbutamol with PMDI and spacer is as effective as salbutamol with a nebulizer, and I show you this in a few slides. How to assess the severity of an asthma attack? There are several scores for this. One of them more frequently used is the PROM score. And this score includes suprasternal retractions, scalene muscle concentration, air entry, wheezing, and oxygen saturation. And you get points for all these different items. So if you look at, and then you get a total score. Mild attacks have a score of 5 or less, moderate 5 to 8, and severe 9. And using a score like this may help you to follow the course of a patient at the ER, even if you have different doctors looking at the patient, because it's quite a more objective score. Although there is also quite some inter-observer variability for this score. Not a more simple table is this one. Moderate asthma attack, children are still able to talk in sentences, have a oxygen saturation above 92%. Peak flow we are not using in our department. Heart rate is important, and respiratory rate, of course. The more acute severe asthma attacks, children can't complete sentences in one breath. They have hypoxemia and a high heart rate and a high respiratory rate. The life-threatening asthma attacks, again, low saturation, poor respiratory effort. Children are exhausted. Confusion is important, and very important, a silent chest. So this is really an alarm sign if you have a child with a silent chest, which may be really difficult for residents that are just starting on the ER. So salbutamol is, of course, the first line treatment, nebulized or with a PMDI and spacer. Ipratropium bromide is added during the first 3 times when you nebulize a child with salbutamol, and then every 6 hours. And corticosteroids should be started in all but the mildest exacerbations. Prednisolone, the dose varies between guidelines between 1 and 2 milligram per kilo for 3 to 5 days. Oxygen to maintain a saturation of 94% at least. And don't forget to give epinephrine if you suspect an anaphylaxis. PMDI plus spacer, 100 children 2 to 14 years presenting with a severe exacerbation, and in these children salbutamol and ipratropium with a PMDI and spacer were compared with nebulizations, and children with the PMDI received oxygen with nasal cannula. Here you see the results of this study. The oxygen saturation actually increased quicker in the group with the spacer, and the time to reach a asthma score below 6, which was which meant that children were doing better, were less dyspnoic, less tachypneic, was quicker when the spacer was used compared to the nebulizer. So even in children with severe exacerbation, a PMDI plus spacer is at least non-inferior to a nebulizer. And especially in these times of COVID, it might be important. Prednisolone versus dexamethasone or inhaled corticosteroids as steroid treatment. 2 studies showing that dexamethasone, 2 doses or even a single dose may be at least non-inferior to a 3 or 5 day course of oral prednisolone. And a study in the New England Journal 2 years ago showing that quintupling the dose of inhaled corticosteroids for 7 days at the first signs of an asthma exacerbation was not helpful. So this was the right answer, and we already discussed that. So the take-home messages of my presentation are that in step 1 and 2 asthma management, as needed inhaled corticosteroid and as needed inhaled corticosteroid LABA may be an alternative for as needed SABA. And in step 3, determinants of response to the different alternatives are not clear. So you have actually 2 or even 3 alternatives there. In preschool children, the children with a high risk, meaning high eosinophils, sensitized benefit the best from inhaled corticosteroids, and actually viral wheezes do not. And as needed, inhaled corticosteroids may be an alternative for daily inhaled corticosteroids. In acute asthma, PMDI plus spacer is at least as good as nebulizer treatment, and dexamethasone may be an alternative for prednisolone. So thanks for your attention, and happy to take the questions.
Thank you very much, Marielle, for this very elegant overview of a very complicated topic where you could probably easily speak 3 hours, I think.
Yeah.
I have tried to group some of the questions, and I think I would like to start with the questions of the youngest patients. There's the question of use of salbutamol and inhaled corticosteroids in infants, so less than 1 year of age. The first questions relate to resistance or receptors for beta agonists and ICS receptors at this young age. Do they work? And the second question, if we use inhaled corticosteroids, which would be the safest option in this age group?
Yeah, so for the first question, inhaled corticosteroids and salbutamol in children younger than 1 year. I think in children younger than 1 year, I didn't talk about that at all, but there we really should think if this is really asthma or not, and we should be very reluctant to start inhaled corticosteroids, in my opinion. Salbutamol can be needed as a trial treatment, but again, I think you should carefully look at the response of treatment and if children are responsive at all or not, and try to stop treatment as well if there's no response. So I would be really reluctant to start inhaled corticosteroids in the younger children. And the second question was...
Yeah, if you start an inhaled corticosteroid, would you recommend?
Yeah, no, I don't have a preference for one of the inhaled corticosteroids, and there are not many studies comparing different inhaled corticosteroids in young children. So no, I don't have a preference.
Okay. And then if we move up in age for the preschool children less than 5 years of age, the long-acting beta agonists are not licensed. what do you recommend if you have a 4-year-old who would need a step 3 treatment?
Yeah, so they are licensed. Actually, the combination of fluticasone and salmeterol are licensed from the age of 4, at least in Europe. So you could use salmeterol fluticasone in this age group. But a very good alternative, of course, is to double the dose of inhaled corticosteroids in these younger children.
Mm-hmm. And then the
and sorry, maybe to stress that this as needed inhaled corticosteroids LABA combination is only tested in budesonide formoterol combination, and it's only for the older children, for the children from 12 years and older.
Mm-hmm. Thank you for this clarification, but there's a question which relates to that. You've been talking about intermittent corticosteroids for 6-year-old, the TREXA study. What does intermittent mean? Is it just a single dose or is it several days?
It means intermittent when children have complaints, so for several days during periods of complaints.
Okay, and then I found a question regarding the teenager who has symptoms only with sports, as an active teenager. So is this a case where you would give inhaled corticosteroids, although he has no interval symptoms, or is he still all right with short-acting beta agonists?
Yeah, I think this depends, but most children are active and do sports several times a week. So then I would actually start them on inhaled corticosteroids.
And if it's a teenager, that's the ideal candidate for the SMART combination.
Yeah, I agree.
Corticosteroids and formoterol. Mm-hmm.
Yeah.
Okay, so I haven't had the time to follow more of these questions. Maybe Fabio can help me. Purely.
The other questions. So let's go from the top.
Yeah.
So we can ask this question that is, which is the better inhaled corticosteroid, fluticasone, beclometasone, or budesonide?
Yeah, there's no preference. So I would advise to choose one that where you have experience in. Of course, there are some differences. You have the beclometasone extra fine, which means that they are twice as potent as the not extra fine, the normal one. So you should reduce the dose. There is cyclesonide, quite new inhaled corticosteroids, which is only activated in the lung and seems to have a little bit less side effects, systemic side effects. So that might be also an option. But I think the most important is to get experience with some of those medications.
I think another interesting question could be, how long should we use ipatropio in the emergency room? Because we discuss always this topic with my colleagues.
Yeah. So what's in our protocol is that we add ipratropium for the first 2 hours every 20 minutes, and then we continue it 4 times a day.
So you continue it also after the acute, because usually we use the ipatropio only in the first 2 hours, and then we stop. We only albuterol.
Yeah, we continue, but at a lower frequency.
Okay. And probably another question that could be interesting is, which is the role of aminophylline?
Yeah. Well, there might be a role in the very severe attacks, but well, the first steps would then be first to start magnesium sulfate. It's also in the additional slides, including the doses, IV. And if you don't have a response on magnesium sulfate, to start IV salbutamol. So I think that are steps before aminophylline. There might be a place for aminophylline in the ICU. There are also other options like well, we had some children with a real severe acidosis who we gave bicarbonate to because in a real severe acidosis, your beta agonists don't work very well. There are several techniques of anesthesia that can help you in the very severe cases. So there is a role, but only in the pediatric intensive care unit.
Okay.
And the next question is on the use of corticosteroids. Is it, corticosteroids and all, but the mildest exacerbation, isn't that against the steroid sparing paradigm in asthma?
Yeah, I think for the preschool children, it's different. So in the preschool children, actually, there's hardly any indication to give oral corticosteroids, except for the children with real severe wheezing admitted to the hospital. In the older children, this is the best treatment we have. And if we give a short course of prednisolone or dexamethasone, you really should start it in all exacerbations except the children who are doing better after 1 of 2 nebulizations.
And then if you've had an exacerbation, you need to revise your long-term treatment to prevent
Yeah,
exacerbation.
it's certainly recommended to see children after an exacerbation, 1 or 2 weeks after an exacerbation at your outpatient clinic to look at maintenance treatment, at adherence, at inhaler technique, etc.
Mhm.
Okay.
Um,
I think that we're over with the time.
yes, well, yeah, that's right, actually.
I will work on answering all the questions in the chat.
The chat.
Yeah. I think overall we have covered all the topics. So both of you, thank you very much. This was a very lively discussion afterwards. Big topic, and we are now for a 10-minute break before we go on to rare lung diseases.